Hello, my name is Rachel Vreeman. I'm a pediatrician and health services researcher, and I'm the chair of the Department of Global Health and Health System Design at the Icahn School of Medicine at Mount Sinai in New York City. I also am the director of the Arnhold Institute for Global Health at Mount Sinai. Today, it is truly my pleasure to host this virtual panel of abstract presentations that highlight some of the most exciting work in the prevention of mother-to-child transmission, or PMTCT. Now, the World Health Organization and UNAIDS global plan, of course, originally sought to eliminate new HIV infections among children by 2015. Well, we've seen enormous advances in preventing these transmissions, especially, of course, with the move to lifelong treatment of pregnant women with HIV or option B, and then more recently with treatment for all persons living with HIV. Mother-to-child transmission of HIV does remain a significant contributor to the HIV pandemic, accounting still for 9% of our new infections globally. UNAIDS reported that in 2019, an estimated 150,000 children were still newly infected with HIV that year, and almost 2 million children are still living with HIV globally. Now, as we continue, we are expanding our understanding of the impacts of the prenatal HIV exposure on children and of ART exposure for children who are HIV uninfected but exposed to a mother living with HIV. Some of the abstracts in this session will highlight new work in this area. And for many of us, these developments related to PMTCT exposures and the potential risks versus benefits of PMTCT have been very much at the top of our minds, especially as we've worried in the last 2 years about the potential link between dolutegravir and neural tube defects. It was incredibly encouraging in July to hear an update from the Tsepamo study in Botswana at AIDS 2020, where Dr. Rebecca Zash's data further supported the WHO's 2019 decision to continue recommending dolutegravir. And we're delighted that the data continue to show that infants born to mothers who are on dolutegravir from conception were not significantly more likely to have neural tube defects. Today, we get to hear some highlights about the newest findings related to PMTCT and these exposures. You'll hear all of the authors present their abstracts with recorded presentations, and then we're going to have a live time for question and answer at the end of the session. Our first presenter today is Dr. Gillian Pintai. The abstract being presented is titled Extent of In Utero Transfer of Tenofovir from Mother to Fetus, a Paired Analysis of Hair Specimens Collected at Birth from a Cohort in the United States. Dr. Pintai is from the University of Washington in the United States. Thank you.
Thank you for listening to my talk today. On behalf of our collaborative study team from the University of Washington, UCSF, and Harvard, I thank you for the opportunity to present our work. By 2016, 76% of all pregnant women living with HIV globally used ARVs during pregnancy. Tenofovir-containing combination ART is currently recommended as first-line HIV treatment. Tenofovir disoproxil fumarate, or TDF, in a fixed-dose combination with emtricitabine is also recommended for PrEP to prevent HIV acquisition in populations with substantial HIV risk, including pregnant women. As global efforts intensify to eliminate vertical HIV transmission and prevent HIV, the likelihood of women using tenofovir during pregnancy is increasing. Tenofovir exposure during pregnancy appears generally safe. However, data suggests that any in utero ART exposure may be associated with more frequent adverse outcomes. Understanding the pharmacokinetics of in utero tenofovir transfer is critical for interpreting safety data and unraveling underlying pathways of potential toxicity. Limited prior studies have evaluated in utero tenofovir transfer by employing measures that reflect short-term exposure in the infants, and these studies have generally shown high rates of transfer. Unlike short-term measures, neonatal hair can quantify prenatal in utero exposure to maternal medications over time. This figure at the bottom illustrates how hair measures quantify an average cumulative exposure as compared to plasma and other measures which provide a snapshot of short-term exposure. To date, tenofovir hair levels have not been harnessed to quantify cumulative tenofovir exposure in utero. Using data from their surveillance monitoring for ART toxicities, or SMART cohort, which is a prospective cohort of pregnant women living with HIV conducted by the NIH-supported Pediatric HIV/AIDS Cohort Study Network, we evaluated in utero tenofovir transfer by measuring maternal and infant tenofovir hair concentrations at birth. All pregnant participants in the SMART study with a delivery date between June 2014 and July 2016 were eligible for the hair sub-study. Pregnancies with no reported maternal ART use, no maternal consent for hair collection, or lack of maternal scalp hair were ineligible. And small hair samples of about 100 strands were collected at a single time birth point at or shortly after childbirth. Tenofovir hair concentration in the proximal 1.5 centimeters of hair, representing approximately 6 weeks of exposure, were analyzed using validated liquid chromatography tandem mass spectrometry methods at the UCSF Hair Analytical Laboratory. The weight-normalized tenofovir hair concentration outcomes were log transformed to approximate a normal distribution, and we assessed the degree of in utero transfer of tenofovir from mothers to infants by calculating ratios of infant to maternal hair concentrations. To identify covariates associated with in utero transfer, we use univariable linear regression. Overall, 103 pregnancies had maternal tenofovir levels above the lower limit of quantification, were singleton births, and were included in this analysis with their infants. Pairs in which the mother's level was below the lower limit of quantification were excluded because these are not compatible with any amount of transfer. 10% of deliveries were preterm before 36 weeks, and slightly over half of deliveries were C-sections. 8% of mothers had unsuppressed viral loads in late pregnancy, 31% of mothers used NNRTIs during pregnancy, 57% used PIs, and 37% used INSTIs. The median duration of TDF used during pregnancy was 32 weeks. 80% of infants had tenofovir hair levels above the upper limit of quantification, and you can see them clumped at the top here. The infant tenofovir hair levels are on the y-axis and the mothers are on the x-axis. The Spearman coefficient between the maternal and infant tenofovir levels was 0.2, suggesting a weak yet statistically significant correlation. For reference, this table presents the mean, median, and absolute ranges of raw weight normalized tenofovir hair concentrations for both mothers and infants, but I want to draw your attention to the last row outlined in red here, which are the infant to mother ratios of these values. The mean log ratio of infant to maternal tenofovir levels was 1.08, and the median was 1.21. Tenofovir transfer was 60% lower for mothers who had preterm deliveries compared to term, and 42% lower for mothers who had C-section deliveries compared to vaginal. And higher tenofovir transfer was associated with having black infant hair color and maternal achievement of high school graduation. We also tested use of other ARV classes as potential correlates of in utero tenofovir transfer, and we found that INSTI use during pregnancy was marginally associated with lower tenofovir transfer. PI and NNRTI use were not associated. As expected, pregnancies with TDF use only in the first trimester also had lower transfer. In conclusion, prior studies have assessed in utero tenofovir exposure via short-term metrics in plasma, cord blood, amniotic fluid, and meconium, and estimated infant to mother tenofovir ratios of about 0.6 to 0.88, with our study confirming that such transfer is cumulative. We did find some factors associated with transfer, but our results should be interpreted with caution given the small sample size, and our method of measuring tenofovir impaired hair samples could be applied to future studies assessing maternal to infant transfer and safety of newer ARVs being disseminated globally, like dolutegravir or TAF, and novel ARTs currently in development for HIV treatment and prevention. Future studies are needed that evaluate objective measures of in utero exposure to ARVs in relation to infant outcomes. I gratefully acknowledge the study participants and the FACS community. I thank the NIH for funding the R21 for this study. I grew up scientifically through this project as MPI together with one of my mentors, Dr. Monica Gandhi, and I thank the NIH for supporting the work of young investigators like myself. And I also gratefully acknowledge my COI and study team. Thank you.
Thank you so much for that presentation. Our next abstract is going to be from Dr. Alka Kaitan. Dr. Kaitan is presenting children who are HIV exposed and uninfected exhibit immune suppressive plasma biomarker profiles. Dr. Kaitan is from the Indiana University School of Medicine in the United States, and we will now turn it to her.
Thank you to the organizers for inviting us to present our data. Nearly 15 million children are living globally who were exposed to HIV yet uninfected, referred to as HEU. A number of studies demonstrate that HEU have higher morbidity and mortality than HIV unexposed counterparts, or HU. In children with perinatal HIV infection, chronic immune activation lies at the heart of long-term morbidity. Interestingly, HEU also exhibit immune activation despite a negative HIV status. They exhibit a pro-inflammatory cytokine profile and T-cell activation in early infancy. However, it is unclear whether these immune perturbations persist through childhood. We evaluated plasma biomarkers in toddler-age children who were HEU or HU. This study was a cross-sectional pilot study nested within the project, assessing neurodevelopmental delays in children born to HIV-infected mothers in Western Kenya, a pilot study led by Drs. Megan McHenry and Aaron Oyungu. The setting was the academic model for providing access to healthcare, or AMPATH, in Western Kenya. Children who were HEU or HU between the ages of 18 to 36 months old were enrolled between December 2017 and September 2019. Plasma samples were collected and cryopreserved in Kenya and shipped to Indiana University for analysis. A total of 82 participants from the parent study had adequate plasma samples for our study. This included 44 HEU and 38 HU. The median age for HEU and HU was 22 and 24 months respectively. This was a statistically significant difference, which we accounted for in our multivariate analysis. Sex was matched between groups with 19 males in each group. We measured 81 plasma biomarkers using magnetic bead-based multiplex platforms. We used two kits, the 65-plex human Procarda-plex kit by Invitrogen and the human immuno-oncology checkpoint protein panel kit by Millipore Sigma. The biomarkers included in our panels are shown here. There were 24 pro-inflammatory cytokines, 18 chemokines, 11 growth factors, 3 markers of endothelial activation, and 8 inhibitory and 8 stimulatory soluble immune checkpoints. Of the 81 plasma biomarkers that we measured, 14 were significantly different between children who were HEU versus HU. Those that were lower in HEU compared to HU are highlighted blue, and those that were higher in HEU are highlighted red. These are the 12 biomarkers that were lower in HEU compared to HU, shown here with median values and interquartile ranges. They include 5 chemokines, 2 growth factors, and 5 pro-inflammatory cytokines. IL-12 and TWEAK were the most significant of these biomarkers. Notably, IL-12 is a Th1-inducing pro-inflammatory cytokine that is produced by activated macrophages and dendritic cells. It stimulates interferon gamma production by T cells and NK cells. TWEAK, or TNF-like weak inducer of apoptosis, is a cytokine in the tumor necrosis factor superfamily. Of the soluble immune checkpoints, 2 inhibitory checkpoints, were higher in HEU compared to HU, namely CD40 and TIM3. Soluble CD40 exerts immunosuppressive effects through negatively modulating CD40-CD40 ligand interactions. In vitro studies demonstrate that soluble CD40 suppresses IL-12 production by APCs. TIM3 is a key inhibitory immune checkpoint that has been associated with T-cell exhaustion during HIV. Soluble TIM3 levels correlate with surface expression of TIM3 on CD8 T cells and also with HIV disease progression. Finally, we performed a multivariate analysis to account for potential confounding effects between biomarkers. We applied a Bayesian model averaging, or BMA method, that accounts for uncertainty in our model selection. In our analysis, we included age and 20 biomarkers that differed between HEU and HU, with a p-value of less than 0.1 as variables. The outcome measure was HEU versus HU status. Thus, in the BMA analysis, a total of 2 to the 21 models were considered. Our results showed only 3 significant variables: IL-12, CD40, and IL-13. The PEP value, or posterior effect probability, shown in this table indicates the strength of evidence that a variable determines HEU versus HU status. A PEP score of 0.5 to 0.75 shows weak evidence, 0.75 to 0.95 positive, and greater than 0.95 very strong evidence. The strongest variable in our BMA was IL-12, which is similar to our univariate analysis. In conclusion, HEU had lower levels of 12 pro-inflammatory cytokines, chemokines, and growth factors. HEU had higher levels of inhibitory soluble immune checkpoints, CD40 and TIM3. In our multivariate analysis, IL-12 was the most significant biomarker that predicts HEU versus HU status. Overall, our data shows that toddlers who are HEU exhibit an immune-suppressive plasma biomarker profile compared to HU, which is really contrary to early infancy, in which HEU exhibit immune activation. I'll close by acknowledging my co-authors, the AMPATH team that enrolled all our subjects, and of course our study participants. Thank you for your time, and I welcome any questions.
Thank you so much. Our next presentation is from Dr. Raji Balasubramanian. Dr. Balasubramanian is presenting time to first positive HIV-1 DNA PCR in infants infected with subtype B HIV-1 is delayed in the presence of maternal antiretroviral use. Dr. Balasubramanian is presenting from the University of Massachusetts, Amherst in the United States.
I'm Raji Balasubramanian from the University of Massachusetts, Amherst, and I'll present our work on early infant diagnosis of HIV infection. The goals of our work were to estimate the time to DNA PCR test positivity in non-breastfed HIV-infected infants and to evaluate differences according to exposure to maternal or infant HIV regimen. As background, accurate diagnostic tests to detect HIV infection in infants are critical to ensure early treatment, and HIV DNA PCR tests have been shown to have imperfect sensitivity when given soon after birth. In our previous work, we showed that time to HIV test positivity may be longer in infants exposed to combination therapy. However, our previous analyses were limited in sample size. In this work, we combined data from 2 prospective cohorts in the United States, PACS, or the Pediatric AIDS Collaborative Transmission Study, and WITS, the Women and Infants Transmission Study. From these 2 cohorts, we included all infants who were HIV infected definitively or had indeterminate HIV infection status and who had at least 1 DNA PCR test before age 3 months. We excluded DNA PCR tests with missing results or missing age at time of blood draw and excluded infants whose mother's ARV exposure was not known. In summary, we had 129 HIV positive infants and their mothers from WITS and 299 HIV positive infants and their mothers from PACS. We classified maternal and infant ARV regimen according to the most complex ARV that the mother received in the third trimester or at the time of labor delivery, and infants were classified according to prophylactic regimen, which had a start date that was prior to 45 days after birth. Our groupings of infants by maternal ARV and infant ARV are shown here, and our biggest sample sizes were in the maternal ARV groups of no ARV, single NRTI, those are the first two rows, and the group which is labeled E/F, which corresponds to mothers who received 3 or more ARVs that included at least an NNRTI or API. Infant ARV was grouped according to no ARV, ZDV, or other. This shows the timing of DNA PCR tests in our dataset. On the x-axis is the age at the time of the test. On the y-axis is the number of DNA PCR tests, and tests are grouped according to the cohort, WITS, or PACS. And you can see that we had a good number of tests from birth up to about 3 months of age, after which the number of test results drops off pretty sharply. Participant characteristics according to maternal ARV groupings are shown here, and characteristics, especially CD4 count, gestational age, were roughly similar across the different maternal ARV groups, whereas viral load was lowest amongst mothers who received 3+ ARVs or the E/F group relative to mothers who received either no ARV or single NRTI as expected. We used methods for interval sensor data and regression modeling to adjust for potential confounders in our analyses. Our main set of results are from unadjusted models that are shown in this slide, which show the cumulative probability of a positive DNA PCR test when the test is given from birth to 1 day after birth, when the test is given at 14 days, at 30 days, and 90 days. And we have provided estimates for according to groups of maternal ARV exposure. And highlighted in bold are our groups with the largest number of infants, which corresponded to infants whose mothers received no ARV, infants whose mothers received single NRTI only, and infants whose mothers received 3+ ARVs that included an NNRTI or API. We see that amongst infants whose mothers received no ARV or single NRTI, the test positivity when it's given 0 to 1 day after birth was between 25 to 29%, and it rose to between 74 to 81% by 90 days after birth. However, when you look at infants whose mothers received 3+ ARVs, the test positivity rate at the time of birth was just 5%, and it rose up to a maximum of 20% by 90 days. And these differences were statistically significant due to the confidence intervals that were non-overlapping. In this slide, we show the statistical significance of the maternal ARV group with respect to time to DNA PCR test positivity in unadjusted models in the column in the middle and adjusted models in the column at the very end. And the adjusted models particularly included maternal CD4 and viral load obtained at a time close to delivery, as well as gestational age and mode of delivery. We see that maternal ARV is statistically significant with a p-value in the order of 10 to the minus 12 when in unadjusted models, and as well as remained significant in adjusted models. Time to test positivity by infant ARV was not statistically significant in either unadjusted as well as adjusted models. To summarize, time to DNA PCR test positivity was significantly later with receipt of 3+ ARVs when compared to no ARV or single NRTI. These differences in test positivity rates were observed at the time of birth, and they remained statistically significant at 3 months after birth. Adjusting for maternal/infant characteristics did not attenuate our findings. Our study team included Yibai Zhao, who is a PhD student at UMass Amherst, Dr. Mary Glenn Fowler at Johns Hopkins Medicine, Drs. Ken Dominguez and Steve Nesheim from US CDC, and Dr. David Shapiro from Harvard T.H. Chan School of Public Health. We gratefully acknowledge the study participants. Thank you.
We thank you for that presentation. Our next abstract presenter is Ms. Shunan Jessica Lee. Ms. Lee is presenting higher hospitalization rates in children born HIV exposed and uninfected in British Columbia, Canada between 1990 and 2012. Ms. Lee is presenting from the University of British Columbia in Canada.
Hello, everyone. My name is Jessica Lee. Thank you for the opportunity to present on higher hospitalization rates in children born HIV-exposed uninfected in British Columbia, Canada, between 1990 and 2012. Globally, an estimated 14.8 million children are HIV-exposed but uninfected, or CHEU. In Canada, there are 200 to 250 HIV-exposed children born every year, the vast majority of whom are born uninfected as CHEU. Although they experience fewer adverse outcomes than children who do acquire HIV perinatally, there is growing evidence that CHEU are at increased risk of complications compared to children who are HIV unexposed and uninfected, or CHUU, born to HIV-negative mothers. Compared to CHEU experience a higher incidence of hospitalizations, infections, and worse clinical outcomes. Infants born to women living with HIV are also increasingly exposed to maternal antiretroviral therapy, or ART. The risk of hospitalization and infections among CHEU and the effects of antenatal exposure to ART have not been established in a Canadian setting. The purpose of our study was to assess hospitalization and infection outcomes among CHEU in British Columbia, Canada, while considering antenatal HIV and ART exposures on CHEU. We hypothesized that CHEU experienced more hospitalizations in the early years of life compared to their CHUU pairs, and that this difference may be modulated by maternal ART and maternal substance use. This retrospective controlled cohort study used data from health administrative databases. Maternal and child data were collected on CHEU and CHUU born in the province of British Columbia, Canada, between 1990 and 2012. CHEU and CHUU were matched 1 to 3 for age, sex, and maternal forward sortation area. The primary outcome of interest was any hospitalization, excluding those immediately related to delivery events, such as a single live-born born in hospital. Other outcomes of interest included hospitalizations within the first month of life, within the first year of life, post-neonatal hospitalizations, defined as any hospitalization that occurred after 30 days of life, infection-related hospitalizations, and intensive care unit admissions, or ICU admissions. We determined the adjusted odds ratio between in utero HIV exposure, antenatal ART exposure, and child hospitalization outcomes via conditional logistic regression, adjusting for preterm birth. From 1990 to 2012, a total of 446 CHEU and 1,333 CHUU were included. Compared to CHUU, a higher proportion of CHEU were born preterm at 19%. CHEU also showed a greater prevalence of any hospitalization at 47%, hospitalization within the first month of life at 43%, and within the first year of life at 41%, as well as any ICU admissions at 29%. The most prevalent diagnosis of ICU admissions among CHEU was neonatal withdrawal symptoms from maternal use of drugs of addiction. Differences in the proportion of infection-related hospitalizations was not significant between CHEU and CHUU. Infection-related hospitalizations were primarily respiratory tract infections among both groups. After adjusting for preterm birth, CHEU experienced 2.3 times the odds of any hospitalization, 2.05 times the odds of hospitalizations within the first year of life, and 3.38 times the odds of ICU admissions compared to CHEUU. With regard to the timing of maternal ART initiation, CHEU born to mothers who initiated ART pre-conception tended towards higher odds of any hospitalization with an adjusted odds ratio of 1.66, compared to CHEU born to mothers who initiated ART during pregnancy. However, preconception ART tended towards a protective effect for ICU admissions with an adjusted odds ratio of 0.51. In British Columbia, CHEU experienced increased odds of hospitalization relative to control CHUU. A substantial number of them occurred within the first month of life among CHEU and were ICU admissions, particularly neonatal withdrawal symptoms. While it is likely the analysis was not sufficiently powered to detect a significant difference, our findings do suggest that earlier initiation of ART prior to conception may reduce the odds of ICU admission. Our results are limited by the lack of available data on other variables that may influence hospitalizations, including maternal pregnancy conditions, maternal HIV disease severity, medications other than ART, and socioeconomic and psychosocial factors. Women living with HIV receiving ART may be characteristically different from those who did not receive any ART, and may reflect the evolution in ART treatment guidelines from 1990 to 2012. In the early years of the study period, preconception initiation of ART may have indicated more advanced HIV disease. In the current era, women living with HIV who have not initiated ART preconception are more likely to have complex psychosocial factors and may be more affected by social determinants of health. Inferences of the cause of excess hospitalization and ICU outcomes remain limited due to these factors. In conclusion, our study provides population-level evidence within a Canadian context of increased odds of hospitalizations among CHEU. An important insight is the increased frequency and odds of ICU admissions, suggesting that CHEU experience more severe conditions independent of preterm birth. Preconception initiation of ART may mitigate some risk of ICU admissions. As the number of CHEU continues to rise in Canada and globally, further investigations of the multifactorial causes of hospitalizations are warranted. Our findings support careful monitoring among CHEU for adverse health outcomes and the importance of early initiation of maternal ART, and may inform future care strategies of CHEU to reduce hospitalizations. Thank you.
Thank you so much for that presentation, Ms. Lee. Our next abstract will be presented by Ms. Faith Moyo. Ms. Moyo is presenting longitudinal evolution of maternal viral loads during pregnancy and postpartum among women living with HIV in South Africa. Ms. Moyo is joining us from the National Institute for Communicable Diseases in South Africa.
Good day. My name is Faith Moyo, and I'll be presenting on the longitudinal evolution of maternal viral loads during pregnancy and postpartum period amongst women living with HIV in South Africa. I have no conflict of interest to declare. I would like to thank my supervisors for their guidance on this work, my colleagues at NICD, as well as the Elmer Foundation for funding this work. So by way of background, 1 in 3 pregnant women is HIV positive in South Africa, and this translates into about 270,000 HIV-exposed neonates per annum. And we can see from the figure that this statistic has remained constant for about 1.5 decades. HIV screening and antiretroviral therapy coverage rates are very high amongst antenatal clients, at more than 95% in the public health sector. The national intrauterine transmission rate currently sits at less than 1%, and this is according to routine laboratory data. Despite the low MTCT rates, ending pediatric HIV in South Africa is challenged by a number of factors. For example, there is a high maternal seroprevalence rate in the country, such that the current IU rate of less than 1% actually translates to about 240 cases per 100,000 live births. and postnatal transmission rates are estimated to contribute a further 1.5 times to 2 times the IU rate nationally. Secondly, the National PMTCT program contains with high rates of seroconversion during pregnancy and the breastfeeding period. Lastly, viral load monitoring during pregnancy and the postpartum periods appears to be a huge gap in PMTCT. We know that EMTCT requires sustained maternal viral load suppression prior to conception through delivery up to the end of the breastfeeding period. However, without viral load monitoring, this information cannot be ascertained. And so we conducted this study to describe changes in maternal viral control during pregnancy and up to 15 months postpartum among South African women living with HIV accessing care in the public health sector between 2016 and 2017. This was a retrospective cohort design based on analysis of longitudinal data of a synthetic cohort that was created from centralized routine laboratory data. We included women living with HIV aged 15 to 49 years between 2016 and 2017 who received HIV laboratory tests at any public health facility in South Africa during the study period. Now, because there is no marker for pregnancy in the National Laboratory Warehouse, syphilis screening coupled with either creatinine clearance and CD4 count or a viral load test was used as a proxy for pregnancy. And this was according to maternity care guidelines and national HIV treatment guidelines for pregnant women living with HIV. We included all participants that met the study's inclusion criteria. For the results, we managed to identify 178,319 pregnant women from the National Health Laboratory Service Corporate Data Warehouse. At first antenatal care visits, median maternal age was 29.2 years. We found that 48% of the cohort was ART experienced, and an equal proportion was ART naive, and we could not ascertain ART status for 2.2% of the cohort. A limited number of comorbidities were documented for 15,575 women, representing 8.7% of the women who tested positive for at least one of these conditions, that is TB, syphilis, and poor renal function. All the country's 9 provinces were represented, with the majority of the women coming from Gauteng and KwaZulu-Natal provinces. For the evolution of maternal viral loads during pregnancy and postpartum periods, we observed a steady decline from the time that women presented for care at the first antenatal care visit through delivery as well as the postpartum period. We also noted that generally, women who were not on ART at the first antenatal care visit had higher viral loads compared to women who were on ART at the first antenatal care visit, as shown by Figure A. We also noted that women that entered PMTCT care with high viral loads remained with high viral loads throughout the continuum of PMTCT care, as shown by Figure B. Now, for factors that predicted maternal viral load decline, we noted that longer duration on ART, maternal viral load greater than 25 years, a CD4 count greater than 500, and a viral load less than 50 copies per mil at baseline were associated with sustained maternal viral load throughout follow-up. For the discussion, we observed a steady decline in maternal viremia from the first antenatal care visit through delivery, with a slight increase towards the late postpartum period, particularly for women who are not on ART at the first antenatal care visit. We also found that 43% of ART experienced women had a viral load greater than 50 copies per mil at the first antenatal care visit, while 2/3 of pregnant women who were ART naive at first antenatal care visit still had a viral load greater than 50 copies per mil after 3 months of ART use. And then amongst women who presented with viral loads greater than 1,000 copies per mil at first measurement during pregnancy, 30% of them had no follow-up viral loads. Provincial differences in sustaining maternal in sustaining viral load suppression were noted into the postpartum period. We concluded that the South African National PMTCT program has reached the first and second UNAIDS 90/90 targets for pregnant women. However, the third 90 remains elusive. Only 63% of pregnant women reach viral loads less than 50 copies per mil by the time of delivery. These results highlight the need for strengthening adherence to ART, increased viral load monitoring, and rapid reaction to high maternal viral loads. We think that surveillance of maternal viral loads during pregnancy, at delivery, and postpartum period would move the country closer to achieving maternal viral load suppression for improved maternal health and EMTCT.
Thank you so much, Ms. Moyo, for that presentation. And our final abstract will be presented by Alexander Moran. Mr. Moran's presentation is entitled Maternal PrEP Use in HIV Uninfected Pregnant Women in South Africa, the Role of Stigma in PrEP Initiation and Persistence. Mr. Moran is presenting from the University of California of Los Angeles in the United States. Thank you.
Hi, everyone. I'll be talking about maternal PrEP use in HIV uninfected pregnant women in South Africa, specifically the role of stigma in PrEP initiation and persistence. We know that biological and behavioral factors contribute to increased HIV risk among pregnant people. We also know that HIV pre-exposure prophylaxis is a safe, effective, and user-controlled HIV prevention method recommended by the WHO for use among women at high risk of HIV, which they define as incidence of greater than 3 per 1,000 person years. Despite these increased risks and the availability of chemoprophylaxis, uptake of PrEP among pregnant people in South Africa remains low despite the provision for PrEP among pregnant women in government policy as of September 2019. In light of this, we studied the role of anticipated stigma and internalized stigma in PrEP initiation, retention, continuation, and adherence in a cohort of pregnant and postpartum women in South Africa. The PrEP-PP, or PrEP in Pregnant and Postpartum Women study, is an open prospective cohort with a planned sample size of 1,200 participants, of whom 633 have been recruited as of 9 September 2020. The baseline visit includes testing for sexually transmitted infections, HIV and creatinine clearance for PrEP users, and a survey with questions on sociodemographics, relationships, risk perception, partner serostatus, intimate partner violence, substance use, depression, and stigma. PrEP users are given 1 month of Truvada at baseline, return for a 1-month follow-up visit to collect an additional 2 months of PrEP, and everyone regardless of PrEP use returns for a 3-month follow-up visit. We measured 4 outcomes. The first was PrEP initiation, defined as receiving a PrEP prescription at baseline. We included 623 participants. The second was PrEP retention, defined as returning for 3-month follow-up. We included 418 participants. The third was PrEP continuation, defined as initiating PrEP at baseline, returning for 1-month follow-up, and continuing on PrEP through 3-month follow-up. We included 221 participants. The last outcome was PrEP adherence, defined as continuing on PrEP through 3-month follow-up and taking PrEP for at least 25 of the last 30 days, measured by self-report. We included 175 people in this outcome. For stigma measurements, 6 stigma questions loaded into 2 scales of 3 questions each. The first was internalized PrEP stigma with an alpha of 0.811, where an example question is, I feel ashamed of using PrEP. The second was anticipated PrEP stigma with an alpha of 0.777, where an example question is, I think people will judge me negatively if I take PrEP. As far as analytic methods, we used R to run simple and multiple logistic regression and define 2 multivariate models. The first considered internalized stigma and controlled for gravidity, education, gestational age at baseline, and STI at baseline. We controlled for STIs only in the adherence outcome. Similarly, we considered anticipated stigma and controlled for gravidity, education, gestational age at baseline, partner HIV testing or knowledge of serostatus, and STI at baseline, which we only controlled for in the adherence outcome. Our descriptive results are baseline measures collected at the first antenatal care visit. Median maternal age was 25 years with an interquartile range or IQR of 22 to 30 years. Median gestational age was 21 weeks with an IQR of 14 to 29 weeks. Median gravidity was 2 pregnancies with an IQR of 1 to 3 pregnancies. 27% of participants had a partner with unknown serostatus, 35% of participants had an STI at baseline, and 91% of participants initiated PrEP at baseline. We found that women with high internalized stigma were at significantly lower odds of initiating PrEP at baseline compared to those with lower internalized stigma, even after controlling for gravidity, education, and gestational age. Similarly, we found that women with high anticipated stigma were at lower odds of PrEP initiation at baseline compared to those with lower anticipated stigma, even after controlling for gravidity, education, gestational age, and partner HIV status. Not shown here is that high anticipated stigma was also associated with lower odds of PrEP retention at 3 months compared to those who had low anticipated stigma, and the participants who did not know their partner's HIV status or whose partners had not been tested were at higher odds of retention compared to those whose partners had been tested for HIV. Among those who continued on PrEP for 3 months, we found that those with lower education had higher odds of good adherence compared to those with higher levels of education, that those with higher gestational age at baseline had lower odds of good adherence, and that those who had an STI at baseline were at lower odds of good adherence compared to those who did not have an STI at baseline. Based on these results, we found that within PrEP initiation, high internalized or anticipated PrEP stigma is associated with lower PrEP initiation among pregnant women at first antenatal care visit. Within PrEP retention at 3 months, we found that high anticipated stigma is associated with lower PrEP retention at 3 months, and that unknown partner serostatus or a partner who had not tested for HIV is associated with higher PrEP retention at 3 months. Finally, within PrEP adherence at 3 months, we found that among those who continued on PrEP, those with higher gestational age at baseline and those with STI at baseline have lower odds of good adherence at 3 months, and that among those who continued on PrEP, those with education less than grade 12 have higher odds of good adherence compared to more highly educated participants. From this, we see that PrEP stigma can act at multiple steps in the cascade of care, with internalized PrEP stigma acting on PrEP initiation and anticipated PrEP stigma acting on PrEP initiation and PrEP retention. Among those who continued on PrEP, additional factors are important to good adherence, including STI testing and treatment and early engagement in antenatal care. Normalizing PrEP use in the community and encouraging PrEP counseling and information dissemination may reduce internalized stigma as a barrier to PrEP initiation. Finally, offering PrEP to women at high risk for HIV and engaging male partners in testing strategies may reduce anticipated stigma as a barrier to PrEP initiation and retention. We'd like to thank our study participants, the PrEP PP study staff, and the City of Cape Town Department of Health staff. Thank you very much.